Welcome to the deep dive. Today, we're looking at the data for Elton, a 71-year-old stroke survivor. Now, he's on a really rigorous regimen. We're talking Eliquis, a plant-based diet, and a statin cruster.
Doing all the right things, it sounds like.
Exactly. And his standard cholesterol numbers look almost perfect. Yet, a powerful new injectable, Repatha, was just added to his plan. So our mission is to figure out why. What hidden risk factor made that necessary?
And that hidden risk factor is really the whole story here. It comes down to one thing: lipoprotein,
Oh.
or LPA for short.
Okay, so let's start with the good news in his panel. His LDL cholesterol is down to 49 milligrams per deciliter.
Fantastic number.
And his ApoB, which is basically the total count of bad particles, that's only 50. I mean, by any traditional measure, he's achieved optimal risk suppression with his diet and cruster.
Absolutely. Those numbers are what we would call goal. But this is exactly why a traditional panel can sometimes miss the biggest threat.
Because the advanced test showed something else entirely.
It did. It showed his lipoprotein A level was 159 nanomoles per liter.
159. And what's the reference range for that?
Well, to give you some context, the high-risk threshold is anything above 125, so he's well into that high-risk zone.
Wow, that's really up there. So for our listener, what exactly is LPA? Why is it this sort of dangerous independent threat that a statin can't seem to touch?
Yeah, that's the crucial part. LPA is genetic. It's a lifelong thing. You could think of it like a standard LDL particle that has this extra, very sticky protein attached to it.
Sticky, okay.
And that stickiness makes it not just a carrier for cholesterol, contributing to plaque, but it's also a pro-clotting factor. It operates completely independently of your standard LDL.
So statins like Cruster, they're great for LDL, but for LPA?
Well, they pretty much leave it alone. And since Elton already had a stroke, this incredibly high LPA level, it strongly suggests it might have been the primary cause all along, a kind of genetic time bomb a standard test would never see.
Okay, that makes sense. But that brings us to the clinical puzzle. Repatha is famous for, aggressively dropping LDL. If Elton's LDL is already at 49, why add it?
Right. It seems counterintuitive, doesn't it? Why use a sledgehammer when a regular hammer has already done the job?
Yeah, is that modest drop in LPA really enough to justify adding this powerful injectable?
It's a great question, and the justification is really twofold because Elton's a very high-risk patient. First, PCSK9 inhibitors like Repatha are recommended to get the absolute maximum risk reduction, even if LDL is already low.
Okay, so just driving all risk down as low as possible. And the second reason, the LPA angle.
Yes, that's the key secondary benefit. Repatha has been shown, trial after trial, to modestly reduce LPA levels.
And by modest, what are we talking about?
Usually somewhere in the range of 17% to 27%. Now, that might not sound like a lot, but for someone with established disease and a critically high level like 159, that reduction is clinically meaningful.
Okay, so it moves the needle.
It moves the needle. In fact, some trials suggest that patients with higher baseline LPA actually see a greater reduction in heart attacks and strokes from this therapy, and that benefit is separate from just the LDL lowering.
So let's just sort of unpack this for you, the listener. You're on this maximally aggressive plan Eliquis for clotting, Cruster for cholesterol, and now Repatha is hitting both that residual LDL risk and this hidden LPA threat. It's just frustrating that this wasn't tested until 5.5 years after the stroke.
It really is, and I think that brings us to the key takeaway today.
What's that?
Given the profound independent risk that LPA poses, everyone should probably request an advanced lipid panel that specifically tests for it.
Especially if you have a family history of heart disease or stroke.
Absolutely. And if your level comes back elevated, let's say over 75 nanomoles per liter, that's a critical signal to talk with your doctor about much more aggressive cholesterol management.
And it's a rapidly evolving field, right? While Repatha gives a solid reduction today, there are new therapies on the horizon.
Oh yeah, keep an eye on this space. There are novel, dedicated LPA-lowering drugs in late-stage development that are promising reductions of 80 to 90%, or even more. This is going to completely revolutionize how we manage this specific genetic risk.